Hey, welcome back to Dental Edge Board. You are watching part 20 of our Prometric prep collection for general dentists. Down in the description, you will spot links to mock exam. And if you missed any previous videos, just tap the I button at the top of your screen to pull up the complete playlist from the very beginning. And I would like to add one more thing. Don't just skip to the question and answers. Listen closely to the reasoning behind every option and take a second to look at the quick reference diagrams on screen. They are built to help these tricky board concepts actually stick. If you are finding these breakdowns helpful, drop a subscription to hang out for future drops. Alright, let's get right to question number 1. Tooth that needs the most surgical extraction. A. Upper canine, upper third molar, lower third molar, none of the above. The correct answer is C. Lower third molar. Well, our lower jawbone is incredibly dense, and these teeth often run out of room, getting trapped or impacted under the bone. To get them out, surgeons usually have to gently clear some bone away, making it a true surgical extraction. Upper wisdom teeth and canines are tricky too, but their surrounding bone is much softer, making them easier to remove. Moving on to next question. A 34-year-old patient has a painful red lesion, 3 cm in diameter, on his soft palate. What is your diagnosis? Options are A. Major aphthous, B. Minor aphthous, C. Herpetic lesion, D. None of the above. The answer is A. Major aphthous. So when evaluating aphthous ulcers, size and location are your biggest clues. Minor aphthous ulcers are small, that is under 1 cm, and superficial. In contrast, major aphthous ulcers are large, typically exceeding 1 cm in diameter, so a massive 3 cm painful lesion on non-keratinized tissue like the soft palate is a textbook match for major aphthous ulcers. If we look into the herpetic lesions, that usually present as multiple tiny clustered vesicles on attached keratinized mucosa. So let's check out the next question. A surgeon referred a patient to you after implant on 2-4 for prosto, and you have 4 mm vertical space. What do you do? Options are A. Refer the patient back to the surgeon, B. Use screw retained crown, C. Use aesthetic luting cement, D. Keep the crown out of occlusion. The answer is B. Use screw retained crown. So when you get a patient with only 4 mm of vertical clearance, don't send them packing back to the surgeon just yet. While cement retained crowns need around 7 to 8 mm of space to get proper abutment height and retention, screw retained crowns connect directly to the implant platform. This eliminates the need for a tall abutment and allows you to restore the tooth safely with as little as 4 to 5 mm of vertical height. Next question is, alveolar bone proper consists of the following. A. Bundle bone and woven bone. B. Bundle bone and lamellar bone. C. Bundle bone and spongy bone. D. Lamellar and woven bone. The answer here is B. Bundle bone and lamellar bone. The alveolar process is divided into 2 parts. Supporting bone, which include the outer cortical plates and inner spongy bone, and the alveolar bone proper, which is the inner socket bone. Histologically, the alveolar bone proper consists of 2 distinct layers. Bundle bone, where the principal Sharpie's fibers of the periodontal ligament embed, and the lamellar bone, which forms the deeper organized layer behind the bundle bone. So remember, bundle bone plus lamellar bone makes up the alveolar bone proper. Our next question. A 5-year-old child with a wide lesion on the oral mucosa, and his parents said this also occurs in his brother. What is the diagnosis? A. White spongy nevus, B. Lichen planus, C. Leukoplakia, D. None of the above. The correct answer is A. White spongy nevus. When a young child presents with widespread asymptomatic white plaques in the mouth and a family history of the same condition, we must think about the genetic side. White sponge nevus is an autosomal dominant hereditary condition that often manifests in early childhood. It presents as thick velvet-like white plaques on non-keratinized oral mucosa. Lichen planus and leukoplakia are extremely rare in a 5-year-old child and lack this direct hereditary pattern. Moving on to next question. The patient is feeling uncomfortable while eating. There is visible swelling and palpable tenderness of the submandibular gland, along with dryness of the eyes. Diagnosis. The options are A. Sjogren's syndrome, B. Mumps, C. Sialolith, D. None of the above. The answer here is A. Sjogren's syndrome. When a patient reports salivary gland swelling, pain during meals, and dry eyes, here you are looking at a systemic autoimmune condition, that is Sjogren's syndrome. Autoimmune destruction affects both salivary and lacrimal glands, causing dry eyes and xerostomia, which leads to glandular swelling and discomfort while eating. While a cellulite causes swelling during meals, it would not explain dry eyes. Mumps is an acute viral infection that wouldn't typically present with dry eyes either. Moving on to next question. Patient with plasma cholinesterase deficiency, which anesthesia do you use? A. Procaine, B. Prilocaine, C. Procaine with vasoconstrictor, D. Another ester type. The answer here is B. Prilocaine. So plasma cholinesterase is the primary enzyme responsible for metabolizing ester-type local anesthetics like procaine. If a patient has a deficiency in this enzyme, administering esters can lead to toxic systemic accumulation. To avoid severe toxicity, you must choose an amide-type local anesthetic which is metabolized primarily in the liver. So prilocaine is an amide local anesthetic, making it safe for these patients. Avoid all ester anesthetics like procaine, tetracaine, benzocaine here in this situation. Now, intraligamentory injection will result A. Don't affect blood circulation. B. Slightly decrease blood circulation. C. Will cease circulation for 30 minutes. D. Will increase blood circulation. The right answer is C. Will cease circulation for 30 minutes. So when you administer an intraligamentory injection, local anesthetic containing a vasoconstrictor like epinephrine is injected under high pressure directly into the tight periodontal ligament space. This intense hydrostatic pressure combined with local vasoconstriction heavily compresses the microvasculature supplying the apical tissue. So some research shows this causes a transient near complete cessation of pulpal blood flow for about 30 minutes before normal circulation gradually recovers. It's a key mechanism behind why PDL injections provide such rapid, profound anesthesia. Moving on to next one, the muscle attached to the disc of the TMJ that brings about its forward movement is A. Medial pterygoid, B. Lateral pterygoid, C. Masseter, D. Temporalis. The answer here is B. Lateral pterygoid. So the lateral pterygoid muscle plays a vital role in moving your jaw forward and opening the mouth. Specifically, its upper head attaches directly to the articular disc and capsule of the temporomandibular joint, pulling the disc forward during movement. In contrast, the masseter, temporalis, and medial pterygoid muscles are primarily jaw elevators and do not attach to the TMJ disc to pull it forward. So moving on to our last question for today. Which Kennedy class needs no indirect retainer? A. Class 1, B. Class 2, C. Class 3, D. Class 4. The answer is C. Class 3. So, indirect retainers are designed to prevent sticky foods from lifting a distal extension base away from the ridge. Because Kennedy class 1, 2, and 4 removable partial dentures have distal extension bases or anterior liver arms. They experience rotation around the fulcrum line and require indirect retainers. In contrast, Kennedy class 3 is a tooth bone restoration bounded by natural teeth at both ends. Since support comes entirely from teeth, there is no rotational liver action, so no indirect retainer is needed. And that brings us to the end of part 20. Part 21 is already in the works and dropping shortly. Good luck with your preparation, and I will meet you in the next video. Bye.